Hello everyone, welcome to another webinar from the Steps Forward Innovation Academy. Today's topic is integrating behavioral health into value-based care, strategies for success. We'll show real-world examples and lessons learned on how to address challenges and actionable considerations for the future of whole person care and value-based care arrangements. Please note, this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA. Let's take a moment to go over your experience today as an attendee. If you are joining us on Zoom, you will see a dark menu bar either at the bottom or top of your window. There, you can access a selection of resources related to our webinar today, including the slides of our resources on behavioral health opportunities and value-based care. If you do not see either of those options, select the three-dot quote-unquote more button to access the resources. If you are joining us on YouTube or LinkedIn, welcome. You can follow the link in the description to join us here on Zoom and access the resources I just outlined. Once the event concludes, you will be presented with a brief 2-question survey. Please take a few seconds to give us feedback as it helps us tailor our programming choices to your wants and needs in the future. After our webinar concludes today, you will be able to claim 0.5 continuing medical education credit hours. You can follow the link in the Resources tab to the AMA Ed Hub and claim the credit there. Also in the resources, you will see a link to our upcoming webinars. Check out the programming we have planned for the rest of the year and register there all in one step. We're excited to talk about the importance of whole person care and how behavioral health integration fits into the broader value-based care efforts. As we know, behavioral health can play a major role in the care that patients experience. By integrating behavioral health strategies into VBC, whether through proactive diagnosis and treatment, multidisciplinary care coordination, community engagement, or designing new care touchpoints, we can aim to improve clinical and social outcomes for patients in a sustainable way. The AMA recently published a resource that practices can use to guide decisions making around integrated behavioral health care and value-based care, as well as the unique challenges and opportunities that this care integration presents. Our goals of today's discussion are to describe and understand the role that behavioral health integration plays in value-based care arrangements, to identify solutions to common challenges of integrating behavioral health care into value-based care, such as patient attribution, care coordination, network development, and interoperability, and to consider some actionable, sustainable strategies for behavioral health integration that might be applicable in your practice setting. I am excited to be joined here today to discuss some of these integration strategies with 2 physician leaders from UC Davis Health. Dr. Lorin Scher, who is Director of Behavioral Health Integration, as well as Professor and Vice Chair of Education at UC Davis School of Medicine, and Dr. Reshma Gupta, Chief of Population Health and Accountable Care. Lorin, I'll pass it over to you to kick us off.
Thanks so much, Chris. Really appreciate the opportunity to be here with Reshma, with you. The first thing I'll say is that I'm very thrilled that the AMA is interested in this topic, because I think it's very relevant for how we can improve access to behavioral health care, like you said, and then also with helping our patients get better, because so many of our patients access mental health care through primary care, which we're going to talk about. And I also want to say, very grateful to my friend and colleague, Dr. Reshma Gupta, who has been an incredible partner at UC Davis. So I'm pleased to be here to have this discussion with both of you. So thank you. So very briefly, we're going to talk a little bit about our model at UC Davis, just a real world example about how our integrated behavioral health team has partnered with our Division of Population Health, which Reshma will talk about, and our value-based care efforts. But we have integrated mental health systematically across all of our primary care sites, 14 brick and mortar sites, academic clinics, community-based clinics. And I'm not going to read this entire list to you, but as you know, it's so important that we maintain relationships and build relationships with primary care providers. That's the Department of Psychiatry, licensed clinical social workers, marriage and family therapists, psychologists. So we built those relationships through education initiatives. Reshma and I have partnered on screening for the common mental health conditions that you'll see. We do things like electronic consultations to avoid sending sort of easy questions to psychiatrists so that we can save the sicker patients for the Department of Psychiatry and answer as much as we can within primary care. And then we've really built our whole integrated program around the collaborative care model, which I know AMA members are familiar with. We'll talk more about that. And then every one of our sites, in addition to having the collaborative care model, also has on-site psychiatry consultants for when those patients need to be seen and assessed. And next slide, please. So very briefly, the collaborative care model is a very specific model of integrated care. I think your group knows this, but the thing I'll say is that there are now over 100 randomized controlled trials demonstrating that this model works to improve access, to get patients better, to actually have more engaged providers who actually who feel supported by the mental health team. Patients love it, and it's also shown to be helpful from a health equity standpoint. So it's been developed really to treat the common mental health conditions that you see presenting in primary care. So you have the primary care provider taking care of the patient. You have the behavioral health clinician. It could be an LCSW, a clinical social worker, a marriage and family therapist, a psychologist. Many systems also use nurses, behavioral health nurses, working with that psychiatry consultant. And the most important thing is that patients get better, right? They get better with cognitive behavioral therapy, problem-solving therapy, behavioral activation. And if patients are not getting better, we can also step up medications and use both. And so we know that it's a measurement based, it's treat to target, there's good evidence, and it fits really well into a value-based approach to healthcare. And so I'm thrilled to work with Dr. Gupta, who's going to talk more about sort of how our behavioral health integration program has partnered specifically with her population health team.
All right, so we'll advance to the next slide. I'll give you a little bit of background about what Lorin mentioned. So I'm going to give you a little bit of background on what population health is, how it's structured at our organization, because some of this background is vital to understand how to create these best partnerships and what allows these programs around integrated behavioral health to really coincide and be synergistic with improvements in value-based care, but also with sustainability and leadership buy-in. We'll kind of get into that in the next few slides. So our Office of Population Health and Accountable Care at UC Davis Health has a very clear mission that's very much focused on our patients and community, thinking about how we leverage teams and technology to ultimately be very collaborative in partnerships, like I mentioned, but with that compassion to patients and with that focus on equity as well across the full care continuum. And then we're very driven by results, as Lorin mentioned, and metrics that very much tie to value-based care, actionable data, and evidence-based practice. So our structure, I think, is so vital when we think about this work, because without understanding who those partners are within health systems to create scale and growth and the outcomes, it's really hard to integrate behavioral health across the organization. And so our office is organized with health system executive leadership at the top, my own role as chief of population health and accountable care. But then we have connections and a formal network that can be leveraged with nursing leadership across different settings of care, physician leadership across the organization, but also a clinical informatics team that overlays all of the health system data, as well as population health specialists or program managers to drive that work, right? So that we don't start initiatives and have them kind of halt. And I think some of those key operational partners that we have are operations. We rely a lot on ambulatory, but we have a network of collaborators across different settings of care, care transitions, IT, pharmacy, and quality. And it's so important because as we have this goal of ultimately helping our patients to receive high quality, efficient, effective care, we focus on this in a few different ways: reducing care gaps in quality of care, addressing high-risk patient needs, tackling equity and social needs, and then ultimately tying all of that to performance and value-based contracts. We have almost $65 million in contracts in our office, but all of these components interlay to get to those outcomes, right? And so when we think about integrated behavioral health, this falls into quality gaps, like Lauren had just mentioned, some of the screening, high risk patients that often, if we aren't treating these issues, end up being high utilizers, right? Those patients that we see frequently in and out of the medical center, connecting to outcomes like cost. And so ultimately, we have to think about right care, right time, right teams, right settings in these partnerships and collaborations. So next slide. So I want to talk a little bit about what makes this partnership so unique between population health and integrated behavioral health. Here at UC Davis, primarily began with psychiatry and then really took a strong leap into primary care and beyond in terms of where we're implementing. But I want to talk about three things: our rationale, the relationships that were really important, and the resources that we needed to leverage to do this work. So as I mentioned before, the scope of population health is really system wide, right? And so our ability to leverage that network of relationships and the data and all those components is so important for implementation of integrated behavioral health with that network. We also focus beyond just the patients in our contracts, like value-based care contracts, and we really use it as to leverage what is good care across primary care and specialty care, especially patients where we have continuity of practice. And that outcomes are so important not only for the business of our health system and value-based contracts in themselves, but also our market strategy, the broader business of the organization. And so all of these coming together to say that we're an organization that's committed to integrated behavioral health, providing patients, employees, this kind of care actually helps us as an organization negotiate with payers, employers, and other partners in the community. And that really makes a business case. Now, those relationships that get that work done are integrating with operations and clinical leadership that I mentioned, but to the point where we actually integrate with incentive bonuses for some of that leadership to tie to integrated behavioral health, relationships with finance to be able to develop our business case together. So when leaders are seeing the importance of this work, they're getting it from their own finance department. In terms of numbers and frequent meetings, we often are meeting with executive leadership behind the door on a weekly basis. And so as issues come up and we need to bring in new proposals, we're not starting from scratch with this work. And then, as I said, what are those resources? So having an integrated data model that includes claims data, inpatient, outpatient, survey data, patient data that we have reported that's integrated into the electronic medical record, access to our teams for analytics and dashboards, partnership, in really thinking about how do we approach evaluations to make sure that we're saying that programs are really doing what they're doing and we're seeing the outcomes all the way to utilization and costs as well as health outcomes and experience, and then program management support. And so all of these components of how the health system office can integrate with clinical models like integrated behavioral health are so important to sustain over time. Next slide. So I want to share some key strategies. I think this is a question that Lauren and I often get to say, how do you make that business case? How do you get that buy-in? We have a model, but it's small, it's a pilot. And how do you take it where you've been able to take it? So I want to walk through these 5 pillars, and Lauren and I are going to share this a little bit as we talk through this. But first is really understanding, what does leadership care about and why? And so we've mentioned some of these, but I think this list is actually really, really important. So one is clinical care quality. There's no doubt that as clinicians across primary care, specialty care, we want to make sure that our patients are receiving the best outcomes. That's not just on, getting screening as well as getting patients treated with depression, anxiety, and other conditions, but also general chronic care for diabetes and hypertension and so many metrics we look at and get tested on for our accountable care contracts. But we know that those outcomes get better with improved engagement with patients with their care. And we know that some of these conditions in integrated behavioral health have real proven outcomes to improve these. So it's definitely in line. patient experience, of course, reducing unnecessary utilization and costs, as I mentioned before, but also increasing our capacity and throughput through the medical center. They also care about access to care, our performance and value-based contracts, and our brand value, being able to say, in a sense, that our organization is committed to provide this care to patients with continuity, and market strategy and negotiations. The second important key thing for executives is making sure that we have alignment across priorities with a system-wide focus. And what I mean by that is that we're not developing programs that are only focused on just one payer contract or one clinic or one subpopulation, but we're trying to approach this work system-wide to have the greatest benefit. So looking at a clinical perspective, what is that patient experience? What are those patient journeys? And what are the clinical care models that matter? That makes a lot of connection, especially with certain executives that are in charge of the clinical care model, to say, for example, integrated behavioral health is going to be a double, triple, quadruple win when it comes to not only these outcomes, but providing that best clinical model, best practice to patients. And then spanning primary care in implementation and going beyond that into specialty care over time as the program grows. Lorin, I think you might be the best to talk about the relationships that you built across the system with growth.
Thanks so much, Reshma. And I appreciate what you said and appreciate your leadership, because it really does come down to these relationships. And I think as a physician, and I think you can relate to this, most, the way mental health care has been paid for in the United States and even in other countries, but certainly in the United States, has been a source of frustration and pain for providers and for patients for years. The reason we need integrated behavioral health is because, separate insurance companies and many systems are often charged with providing care. And so patients who need care haven't had the access they need. And so building those relationships, having the Department of Psychiatry and our team of, that's interprofessional, interdisciplinary, right? Psychology, social work, marriage and family therapists, nursing, all be at the table, but having connection with executive leadership across the board, making sure we have buy-in from the clinical medical directors, making sure they know how to refer to us. If there are problems with referrals, making sure we have those regular meetings and those relationships so we can understand what the issues are, because the culture of a behavioral health department or a psychiatry department is often different than the culture of maybe primary care. But we also know psychiatric conditions and mental health conditions do not occur in a vacuum. And so we need to be integrated with the system. And so the fact that we have psychiatry and population health and the operations team, the chairs of academic departments, the chief medical officer, right, the nursing leadership, all on the same page is critical. And so it's not perfect, but we have to maintain those relationships. On the results and growth side, we've talked about sort of treating to target. We have to be measuring what we're doing. So that's the way that we have been able to grow, is that pilots turn into successful pilots turn into programs if you can make sure to communicate those results effectively across the organization. And I think that with the support of Reshma, with the support of my department chair and even all the way up to the CEO of the health system, that has allowed us to scale and spread across the primary care operation. Because 10 years ago, we had successful pilots, but we needed to demonstrate that business case in addition to the clinical outcomes case. And so looking at that financial evaluation, I've had more meetings with the finance leadership than I ever thought that I would, but it really makes a difference, because if you can show that you're helping with billing and not losing money, whether it's for the therapists and the psychiatrists for billing, but then also bringing in quality metrics, revenue is a huge deal for a health system and has really allowed us to grow. So yeah, that's just a few comments I would make. And I think, Reshma, you're going to talk a little bit more about incentives.
Yeah, and I'll mention those metrics that you were just talking about, right? So with screening, we mentioned we look at remission. We look at our outcomes with ED visits, hospitalizations, utilizations, experience, all these different outcomes, and then obviously cost. And so when we think about this, I think another important piece is those incentives, holding to those accountability on some of these outcomes for executives. So we've actually gotten to the point with buy-in where our executives are willing to take on some of these outcomes for their own bonuses. And I think that's really, really key. Even across primary care, we do have quality incentive bonuses that they can receive across a number of metrics. And we have aligned with some of these quality measures for integrated behavioral health. And so they're very motivated, right, when we tie those incentives in. And then the other is just more gamification or performance based. We have a annual primary care celebration of quality outcomes, and there's an award, for the clinics that kind of get the best scores or have the most improvement, even knowing that there's variation in population types across clinics, to receive that. And that's been a huge way to create culture change across our clinics. Next slide. So Lauren, I'll pass this back to you on some of those actual outcomes.
Yeah. So thanks, Reshma. And I'll be very brief because we have so much data within our program, but I'll just have time to share a little bit about sort of some access to care data, and then we'll look at the depression arm of our collaborative care program. But when you think about access, if you had come to UC Davis as a patient back in 2017, right, we're talking 8 years ago, and a primary care doc made a referral to psychiatry, it would take 3 months at least to get into the department. And that's not even that bad when you look at other systems across the country. Now within the department, and also within, getting patients into the collaborative care model, meaning a first appointment with a therapist and a behavioral health clinician, is 2 to 3 weeks across our primary care clinics, which we're very proud of because access is so important. Now, if you look at all of the referrals generated by primary care providers at UC Davis, over a third, right, 38% of all new referrals are seen by members of our integrated behavioral health team. And the reason that's so important is that we're getting as many mild to moderate illness patients better within primary care, so we save the sicker patients with bipolar disorder, schizophrenia, suicidal depression for the Department of Psychiatry. And those folks are going to need more longitudinal management from psychiatric experts, right? And so the goal is to see as much mild to moderate mental illness as we can within primary care. And then if you look at our depression remission and response data, first looking at response, 72% of all of our patients who were referred for depression achieve a 50% symptom reduction. That's how we define response within 12 weeks. We're very proud of that. That's very similar to national data and the studies on the collaborative care model. Usual depression care, if you look at most studies within primary care is 19 to 25%. We're closer to 25% for usual care at UC Davis, but it makes a big difference to implement the collaborative care model, which, for what we've talked about, is evidence-based and treat to target. 40% of all of our patients referred for depression are in a remission within 12 weeks. Again, we're selecting for patients we know are going to get better. Cognitive behavioral therapy works for mild depression. So do medications. Patients have a choice. Sometimes they need both. And so we're pleased with that data as well, because our patients get better, and we don't just stop with partial response. We push for complete remission of symptoms. And so next slide, please. But just wanted to share that data, and I'll turn it back to Reshma to talk more about sort of utilization outcomes.
So we partnered quite a bit on looking at some of those hard outcomes on utilization and costs. And I'll kind of go through this real briefly, but what we did is reviewed all of the adult patients who completed the collaborative care model. And we looked at it for a little less than 2-year period, but about 200 patients or so. And the average treatment duration was about 143 days. And if you click forward, I'll kind of walk you through the methods that we use. But for each patient, we identified kind of a 6-month period prior to treatment and then 6 months following that treatment. And then what we did is we looked at these populations at baseline and kind of post-treatment for some of these key outcomes: ED visits, hospitalization, utilization. And what you can see pretty clearly is that in the post-treatment group, we had lower hospitalizations, ED visits, and even med-surg days. So ultimately leading to about a 31% drop in hospitalizations, 15% drop in ED visits, and 23% drop in those med-surg days. So really outstanding outcomes from this program, in addition, and makes sense based on the clinical outcomes that Lauren had just mentioned. Now we'll get to the harder outcome if you go to the next slide, which is the cost piece. So this is our collaboration, right, with finance and being able to bring the health system data to kind of connect with these clinical outcomes. So we worked with our finance team to identify what are the measures from financial perspective that they most care about and that most make sense to tell the story around the avoidable ED visits and hospitalizations. And what we determined is there was average contribution margin and also average net gain or loss. So contribution margin, for those not as experienced in finance, essentially means what the health system is paid for the service minus the variable cost of that service, versus the average net gain or loss is what the health system is paid for the service minus the variable plus fixed costs of that. So from a finance perspective, you want to know both. So we calculated the potential cost savings related to each visit that this population had and compared it with what a general population cost would be if that bed day, for example, was backfilled by the average patient, right? And so what we found essentially is that if you subtract for hospitalizations a cost that was 26,900 for all patients, all payer types, minus what that cost essentially is for those that have participated in the collaborative care model, looking specifically at contribution margins, there is a cost differential, a real cost differential. And so what we did is then we multiplied that amount by the number of visits avoided from the last slide. And essentially for this population, we found about $100,000 savings in contribution margin and about 60,000 savings in net gain or loss. And we can make the argument that if you really tried to expand the program to goal, and you're expanding the number of patients involved in the program, that's going to be just under $500,000 in savings by contribution margin and just over 200,000 savings in net gain for the program. And that is just based on avoidable hospitalizations and ED visits. So then the more value-based contracts we're in addition, that have shared savings or kind of payment performance at the state level, Medicare contracts or other commercial contracts, that is additional revenue, right? Bringing in to the health system. And so there really is a win-win that you can make between quality outcomes, experience, keeping people healthier at home, and the cost and revenue within the organization. Next slide. So I'll kind of quickly go over some key lessons learned from my perspective, which is the importance of pilots are so important to be able to show data and have this data be shared with executives to then say, yes, this is worth investing and growing. Having those interprofessional, interdisciplinary partnerships are so vital. I think Lorin spoke to this even earlier in the growth of the program. And really having broad leadership sponsorship to be able to even do these evaluations, but to really implement it in a way that makes sense for the clinical teams and for operations. And then, of course, rapid data that's reliable and the ability to not just pull the data, but to actually have evaluation support and buy-in, especially from folks like the finance team. Lorin, what about you? What would you say are the biggest lessons learned from your perspective?
I mean, I think I couldn't have said it better to what you said, Reshma. I think, those relationships across disciplines, and I think we're learning that, inpatient medicine has been really focused on teamwork for a long time. But I think outpatient, when you think about primary care, has always been sort of provider and patient. And I think you really have to start to think about a team the collaborative care model and integrated behavioral health models is team based. And so but all of the relationships, all of the structures and health systems, they're messy and complex. And so I think that focusing on education and shared values, shared goals, and then, looking at sort of how to, scale evidence-based programs to bring the improved outcomes and to demonstrate some of the utilization metrics and successes that you talked about. So yeah, agree with that and appreciate everyone's attention. So thank you.
Well, I'd like to thank you both again. I think it's just really exciting to see all the amazing work that you went through, recognizing the natural fit between your behavioral health integration work and your population health value-based care work, but understanding that just that recognition isn't enough, that a lot of time and effort really needs to go in to create the framework to ultimately lead to the successes that you all were able to develop. And obviously that's still ongoing and you all are continuing to evolve the program as well. But it's really exciting to see a lot of those outcomes, but also the ability to be able to actually truly capture that value in a way that makes the most sense ultimately for the patients, but for the care teams and the organization that you all work for. it really creates that true win-win-win scenario that unfortunately is a little bit more rare in healthcare than we would like to see. So that's really, really exciting. Before closing out, we did receive a few questions from some of our audience members and just wanted to kind of run through a few of them before we kind of close out for the day. So the first one, and I'll let you all to determine who makes the most sense to kind of answer that, but the question is, who can bill for the services for these integrated care models, structures, or arrangements?
So
Maybe Lauren.
I'll start with that one. And
Yep.
so interestingly, I mentioned earlier that the collaborative care model is a CMS recognized service. And actually, thanks to the American Psychiatric Association and even the AMA for endorsing, CMS has approved this. There are billing codes for the collaborative care model. And interestingly, the billing codes allow the primary care clinic operation to bill for those codes. And I think that's also really important. And usually there's a relationship where between the primary care network and a department of psychiatry to develop that. But I think it's really important for PCPs and providers to know that billing can go to the primary care providers, and that's important for those billing codes.
Fantastic. Yeah, we have additional resources specifically on that, both for the collaborative care model as well as broad behavioral health related codes that really work within integrated care settings. So for those that are interested, can check out that information as well. The next question is, and Reshma, I think you talked about a little bit of this, and Lauren as well. What are some of the most common metrics used for behavioral health, specifically in value-based care arrangements?
So I think I'll start. Reshma, am I starting with that? Do you want me to start with that one,
Yeah,
or?
go ahead and I'll jump in. Yeah.
Yeah, so I think I think we talked a little bit about it, but when you're measuring depression outcomes, screening for depression using the PHQ-2 and the 9, but also tracking outcomes for depression. We use things like the GAD-7 for anxiety disorders, which is assisting with screening for anxiety disorders, but also for tracking. But then, we've also been implementing SBIRT, right? Screening and brief intervention and referral to treatment for substance use disorders, which includes the audit and the DAST. There are many other tools that we can use for treat to target or for other illnesses, but those are some of them. Reshma may want to mention a
Yeah.
few other metrics too that are important for
I think
IBH.
no, and I think you're mentioning kind of the main clinical ones, and we shared some of the broad metrics we look at, but we look broader than what we're actually held accountable to these contracts. So the contracts really focus mainly on screening. I think not all of them have actually jumped to remission, but there's a movement towards that. But screening for sure, and that's a big one. But I think there's indirect measures too, which is just what I was mentioning about utilization and cost. You have to understand who's driving and what the underlying reasons are for utilization and cost. And this by far is almost always a driver of it. So if you know how to synthesize your own data, understand what populations are driving it, there's a one for one there kind of indirectly. And so I think those are the key metrics, right, that they hold us
Yeah,
accountable to.
I think that part is really key. I think often in this space, there's that look for the behavioral health specific measures, or in a reality that there are a ton of other measures that has a direct interconnectedness, right, with what's happening on the behavioral health end, and you can actually capture that value. I know you mentioned readmission rates, but also other specialty settings, right? Diabetes care, hypertension. There are other spaces that are also not going to necessarily have behavioral health specific measures, but you absolutely can show the value and the impact on those other measures. And I think you all did a great job of kind of outlining some of those opportunities that hopefully folks can see when they look at some of these contracts, and maybe see, get disappointed where maybe they don't see as many key measures specific to that area, where the reality is they're there. They just don't say behavioral health next to them, but it doesn't mean that you can't have impact there. So I think that's fantastic. The last question that we have is specifically around how to approach insurance companies, commercial health insurers, others, right, that include other models like PCBH in their value-based care programs.
Yeah, and I think I'll jump in on this one because I'm kind of more in communication with some of the payer groups. Um, The payer groups and employers, right? This actually gets to both. So if we're talking about direct contracting with employers, or we're talking through insurance, or either way, the goals are to keep their clients or their employees healthy. And behavioral health related concerns, I mean, all the literature shows, like, what does that mean in terms of time away from work and time healthy at home and time being able to actually function on the job, or otherwise? It is having really good high rates of well-controlled depression, anxiety, and other conditions, and they relate to all these other chronic conditions that you mentioned. And so I think there really is a lot of interest in, from payers almost universally to say, like, what are your rates of these, if they're trying to negotiate not only chronic conditions, but this being a major one that not only in itself needs to be treated, but is connected to the other ones like we mentioned. The other is there's consultant groups that work with employers all the time now that are saying, hey, when you go and make contracts, these are things to look at. Do they have patient-centered medical home? Do they have integrated behavioral health? Are they considered a high functioning advanced primary care service? That automatically means integration with behavioral health. So this is happening all over the country. And so it has to be paid attention to, I think, as we go forward.
Fantastic. And I think we've seen a lot of movement in just the broad education of what behavioral health integration really means, right? And the spectrum of models that really encompasses, and really the North Star is really that improved patient care and outcomes and the opportunities of some of these services, right, to allow them to achieve those goals, regardless of where kind of you are on that spectrum. Understanding collaborative care, Lorin, I think, as you outlined, right, has a really strong research base and really strong opportunities for outcomes, specifically on certain populations, right, especially mild or moderate sense. So it's just another tool in the tool belt to be able to get to the outcomes I think everybody is really striving to get to. So I just want to thank you both again for your time and your expertise. This was a fantastic conversation. A reminder for our audiences, when we conclude today, you will see our feedback survey. Please, please, please take the time to answer these 2 questions. Your responses really do help us guide our upcoming program to deliver webinars you want to see, such as the one you saw today. This recording will be available to review on demand with the link you used to join today. Another resource that we referenced earlier is the Behavioral Health Opportunities and Value-Based Care Practice Guide. This is a new AMA resource which offers key considerations for practices as they seek better incorporating behavioral health care into value-based care arrangements, highlighting some high-level challenges, strategic opportunities. It also delves deeper into a variety of arrangements seen in behavioral health integration, as well as key regulatory considerations for initiating behavioral health offerings within these types of arrangements. This resource, as noted before, is linked in the menu bar at the bottom of your screen. Additionally, our year-long value-based care series wraps up next week on November 11th. Join this live webinar to explore how cutting-edge technologies like augmented intelligence, cloud platforms, and advanced analytics are transforming data sharing and value-based care arrangements. Finally, if you're looking for something more of an in-person interaction from AMA Steps Forward, we would like to invite all attendees to join us for our next Savings Time Practice Innovation Bootcamp in Chicago next April. This 2-day in-person bootcamp is specifically designed for clinical and operational change agents looking to eliminate unnecessary work and free up more time to focus on patient care. If you have interest in attending, follow the link in the Resources tab. Lastly, for additional resources and guidance to support your physicians and staff, including those on value-based care and behavioral health integration, please visit the American Medical Association website or stepsforward.org. Thank you again for joining us. We hope to see you again soon.